It's periradicular surgery. We can also call it endodontic surgery. There is a pathology in the periradicular tissues of the tooth. It's periradicular surgery. Okay. And this pathology has somehow the result of infected necrotic pulp that has caused apical periodontitis initially, and when unchecked, it leads to development of a periradicular lesion. When the periradicular lesion develops, majority of the time it resolves by non-surgical root canal treatment. If there are certain cases where the non-surgical root canal treatment fails, we can attempt a retreatment also. And suppose the retreatment also fails, then the only solution left is the periradicular surgery. The periradicular surgery should always be considered as an adjunct to non-surgical root canal treatment and not as a separate treatment. I hope you understand what I'm trying to say. It is always an extension of. So, what would be done first? Always non surgical root canal treatment should be done first. And if there are certain clinical conditions that warrant surgical procedures, like there is a post and core done in the canal, which is irretrievable, I have no other choice than to go to the periapex in a retrograde manner via surgical means. Suppose there are anatomic perforations over there that cannot be repaired orthogradely, then I have to go for a periradicular surgery. So, surgery is always an extension of non surgical root canal treatment and never a primary treatment or a separate treatment. With that background, firstly, we'll talk about the different steps involved in the surgical procedure. What are the steps involved? The first step in the surgical procedure is definitely securing good local anesthesia. Any and every surgical procedure would require sufficient and adequate local anesthesia so that it is comfortable for the patient to undergo the surgical procedure. Now, this local anesthetic is principally the same anesthetic that we have been using regularly for other procedures like root canal, etc. The only difference that is important is the choice of agent, which local anesthetic agent we would be using. Whatever we use, normally we use 2% lidocaine hydrochloride. This should be with epinephrine, which is a vasoconstrictor. We know that the potency of LA is increased with epinephrine as well as the potential side effects are decreased because of lesser systemic absorption. This epinephrine should have a higher concentration in the ratio of 1 is to 50,000. 1 is to 50,000. This is a significant difference from local anesthetic employed for other procedures like doing root canal therapy, etc. That in surgical cases, we have to use a higher concentration of epinephrine that is in the range of 1 is to 50,000. You will remember that for other procedures, general non-surgical procedures, the concentration of epinephrine is in the range of 1 is to 80,000 to 1 is to 1 lakh. Here we use a higher concentration, and this provides for better hemostasis. Hemostasis means blood control. We get better view of the surgical field when we are using a higher concentration of this epinephrine. What would be the second step? The second step in the surgical procedure would be the flap. We have to raise a mucoperiosteal flap. If we talk about the flap designs, then for these surgical procedures, there are two principal flap designs, which are designated as full thickness flaps and partial thickness. I'm talking about the flap designs used for periradicular surgical procedures. Now, technically speaking, these two terms, the full thickness and the partial thickness, they are misnomers. Misnomers means they are the inaccurate terms to describe the type of flap, because in both the cases, whether it is full thickness or partial thickness, we lift the entire mucoperiosteum and expose the bone completely. So technically speaking, there is no difference in the thickness of the two flap designs, but over the years, this nomenclature has persisted. So they are designated as full thickness and partial thickness. So what is the technical difference between the two types of flap designs? The technical difference is in the location of horizontal incision. How the two type of flap designs are different from each other? From the location of horizontal incision. Whenever any type of flap is to be designated as full thickness, the location of horizontal incision would be inside gingival sulcus. Okay. And whenever we have to designate a flap as a partial thickness, the horizontal incision would be located in attached gingiva. Attached gingiva. This is about 2 millimeters coronal to mucoperiosteum, mucogingival junction. Okay. So principally, what is the difference between the two type of flap designs? The location of the horizontal incision. If it is inside the gingival sulcus, we designate it as full thickness. And if it is in the attached gingiva, we call it partial thickness. The different type of flaps that can be used with the full thickness design are the envelope flap, triangular flap, rectangular flap, trapezoidal flap, and papilla base flap. These are the 5 types of flap designs designated as full thickness flap, means the horizontal incision would be located inside the gingival sulcus. If this is the quadrant of teeth where we are doing the surgical procedure and we make an intrasulcular horizontal incision like this, okay, with very short vertical incision, it is called envelope flap design. Okay. If this is the quadrant of teeth, we make an horizontal intrasulcular incision, which is the fundamental difference, and one vertical releasing incision. It is a triangular flap. If this is the quadrant of teeth, we make a horizontal intrasulcular incision. As you can see, the horizontal incision would always be inside the sulcus, and two vertical releasing incisions which are straight. It would be a rectangular flap design. If this is the quadrant of teeth, we make a horizontal intrasulcular incision with two oblique, with a broad base, vertical releasing incisions. You can see the shape would be a trapezoidal flake. If this is the quadrant of teeth, we are doing the root canal. And followed by surgery. There would be an intracellular incision, and through the base of the papilla we give it intracellular incision, through the base of the papilla, intracellular incision through the base of the papilla. But two vertical releasing incisions. It is papilla base flap. Papilla base means we do not include the interdental papilla into the flap design. Instead, the horizontal incision goes through the base of interdental papilla. So these are the schematic diagrams to illustrate the different types of full thickness flaps. You can see the horizontal incision is always inside the gingival sulcus. On the other hand, if we talk about the examples of partial thickness flaps, one example is Luke oxen bean flap. Luke oxen bean. B is silent in this, L-U-B-K-E, Luke oxen bean flap. This is also called submarginal rectilinear flap. Submarginal rectilinear flap. And another example is semilunar flap. These are the two examples of partial thickness flaps. If this is the quadrant of teeth and we place a horizontal incision into the attached gingiva with two vertical releasing incisions, it becomes a Luke oxen bean flap. You can see what is the difference, how it is different from the full thickness flap. The location of the horizontal incision. It is inside the attached gingiva, so it is called Luke oxen bean flap. If this is the quadrant of teeth we are doing surgery with, and we place a incision like this through the attached gingiva into the mucogingival junction, it is a semilunar flap. Semilunar flap is least desirable because it heals with scar formation. It would result in formation of unsightly scar at the site of surgery. Especially it's to be avoided when we are doing in the anterior segment because it can result in unesthetic healing of the soft tissues. So these are the different types of flap designs. Now, if we talk about the vertical extent of flap, how much deep inside the sulcus we have to give the flap? What should be the vertical extent? It should be 0.75 centimeter above root apex. Vertical incision means how much should be the, if this is the root length, then the distance from the flap termination to the root length should be 0.75 centimeter, and this applies to both the partial thickness as well as the full thickness flaps. Next, we'll talk about flap reflection. Flap reflection. Flap reflection is always started in the vertical incision. It is always started in the vertical incision. If this is a flap design, whatever, whether partial thickness or full thickness, we would insert the periosteal elevator inside the vertical incision and extend it apically and coronally. Okay, this is called undermining reflection. This type of flap reflection is called undermining reflection of the flap. Okay, never started in the horizontal incision but into the vertical incision. These are the important points to be remembered for the flap design. Then after reflecting the flap, when we have lifted the mucoperiosteum above the bone, we have to do osteotomy. Osteotomy means we have to create a window in the bone to gain access to the pathology. At times, the bone is already resorbed. We have to simply modify the bone window. In certain instances, the pathology is entirely confined in the cancellous bone and the cortical bone is not damaged. So to gain entry to the pathology, we have to make a window in the bone. So the best suited burr is a round burr. Round burr is best suited to create an osteotomy, and it is used in gentle brush stroke manner. Gentle brush stroke manner that should be used to create a bone window. And from the definition of burr, you must be having a knowledge that it is a bladed cutting instrument. So we would not use a diamond point, but we would use a tungsten carbide or stainless steel burr, round in shape to create a window in the bone. This causes minimum bone necrosis because the heat generation is restricted with this design of burr. And remember, it would be a bladed cutting instrument. Then, after making entry to the root apex through the bone window, okay, we'll do a root end resection. The root end through which the pathology has associated, we have to resect the root end. Root end resection, two important points to consider with the root end resection is the extent of resection. And secondly, we have to talk about the angle of resection. Means how much of the root end should be cut off and what should be the angle of resection. The extent of resection can be categorized as it can be either 1 millimeter of the root end is cut off, or 2 millimeter of the root end is cut off, or 3 millimeter of the root end is cut off. Means if this is the tooth, we are talking about how much should be the extent of resection, 1, 2, or 3 millimeter. We know that the principal root canal, especially in the apical one-third, divides into several branches and give rise to structures like apical ramifications and accessory canals. So in the apical one-third, there are structures like apical ramifications and accessory canals. Isn't it? The principal root canal is dividing into numerous branches to give it like this: apical ramifications and accessory canals. These all harbor microorganisms, and whenever we are doing surgery, it is imperative that we remove these structures, whether accessory canals or apical ramifications, by way of root end resection. So if I am cutting 1 millimeter of the root, nearly 40% of the apical ramifications and nearly 40% of the accessory canals are eliminated. Eliminated means they are removed. If I increase the extent of resection to 2 millimeter, nearly 74% of the apical ramifications and nearly 56% of the accessory canals are eliminated. On the other hand, if I increase my extent of resection to 3 millimeters, 98% of the apical ramifications and 93% of the accessory canals are eliminated or removed. As we can see, 3 millimeter, it is the most recommended extent of resection because it ensures the maximum removal of accessory canals and apical ramifications, which are the structures that can harbor numerous necrotic microorganisms and pulpal tissue, which has to be removed during surgery. If we talk about angle of resection, angle of resection conventionally has been 45 degrees or beveled resection. the beveled resection of the root end. And the recommended angle of resection is 90 degrees flat, or we can say perpendicular resection. Okay, this is a example of beveled resection. If we see it from buccolingual direction, this is the buccal and this is the lingual or the parietal direction. The root is cut off at a oblique 45 degrees angle. If we cut it flat, this is 90 degrees resection. This is 45 degrees resection. So contemporary endodontic surgery has a recommendation that there should be a flat or perpendicular resection. Why? There are several advantages of flat or perpendicular resection, 90-degree resection. What are the advantages? Firstly, it exposes lesser number of dentinal tubules. We know that dentin is present all around the tooth. It is present in the root of the tooth also. So when we cut it in a beveled manner, the surface area is increased, so it exposes greater number of dentinal tubules that can serve as a pathway of infection from the periradicular tissues to the root canal and vice versa. Isn't it? So to minimize the number of dentinal tubules being exposed, we have to go for a flat resection. Second advantage is it has got better stress distribution. Okay, the root tips are thin, and if we do an oblique resection, there are likely that the root would fracture as compared to a flat resection. And thirdly, it achieves a better root end preparation. Isn't it? If there is an oblique surface, the stability of the root end preparing instrument would be less as compared to on a flat surface. So better root end preparation is achieved when we are going for a 90 degrees of flat or perpendicular resection as compared to a beveled resection. These are the two important aspects of root end resection. Then we'll talk about next step, that is root end preparation. After resecting the root end, okay, this is the root end that has been resected. We prepare a class 1 cavity of 3 millimeter depth in the resected root end. So this is the resected root end. In this resected root end, we will prepare a class 1 cavity. Class 1 cavity means it is surrounded by the tooth structure on all sides, which is of 3 millimeter depth, and the walls of the cavity that is to be prepared is parallel to root canal outline. It is parallel to root canal outline. So a 3 millimeter depth cavity is prepared, walls parallel to the root canal outline. How can we prepare a 3 millimeter deep cavity? So there are different methods for root end preparation. The conventional method is just like we do a tooth preparation on the cornal aspect of the crown. For any restorative material, we most likely use a burr and a handpiece. So the first method is burr with handpiece. But reaching the apical end of the root through a small bone window that we have created is very challenging, and it is very technique sensitive. So for this, we use a special handpiece that is called Impact Air 45 handpiece. Impact Air 45 handpiece. What is Impact Air 45 handpiece? This handpiece has a head that is bent at a 45 degrees angle to the shank. Okay. The head of the handpiece is bent at 45 degrees angle. This is impact air 45 handpiece. And another property is that the air vent is at the back instead of at the head. The air vent is at the back, so there are minimal chances of tissue emphysema or air entry into the tissues. And because of the head of the handpiece is bent at 45 degrees angle, it provides a better access, easier access to the apical part of the root to prepare a cavity. But there are certain disadvantages of using a burr with a handpiece. Firstly, it generates a lot of smear layer. What is a smear layer? Whenever the dental hard tissues are cut, there is generation of a microscopic layer consisting of altered hydroxyapatite and collagen fibers that is called smear layer. So whenever we are cutting the tooth structure with a handpiece and a burr, a lot of smear layer is generated, and this smear layer can compromise the seal of the root and filling material. Secondly, it is less conservative. Even when we are using an impact air 45 handpiece, we would require a substantial amount of bone window to gain entry to the root pecks. So it is less conservative, or we can say bone removal is more. For gaining entry to the root end, we require a larger bone window. So it is a traumatic surgical procedure. Second method of preparing the root end cavity is ultrasonic tips. We use ultrasonic tips. These ultrasonic tips, they can be uncoated, diamond coated, or zirconium nitride coated. Zirconium nitride coated. These ultrasonic tips, which are coated with zirconium nitride, they are also called Kim's ultrasonic tips. Kim's ultrasonic tips. So these tips are available in different dimensions, different shapes of the tips are available, and they are coated with diamond or zirconium nitride at the tip of these ultrasonic tips. So if we talk about their advantage, they cause less smear layer generation. Okay. Second advantage of ultrasonic as compared to burr and handpiece is that it is more conservative. It is more conservative means it requires a lesser bone window because ultrasonic tips are bent at various angles, and they require minimal amount of bone to be removed to gain access to the tip of the root. Disadvantage, if we talk about, because of ultrasonic vibrations, there are chances of root fracture, isn't it? We are using ultrasonic vibrations in the range of 25 to 30 kilohertz. These vibrating ultrasonic tips, when used at the thin root end, they can cause fracture of the root end. These root fractures, they are principally of three types. What are the three types of root fractures that can occur? Intracanal, extracanal, and communicating. . Intracanal fractures, extracanal fractures in communicating. This is the resected root end. Okay, here also this is the resected root end into which we are preparing a cavity with ultrasonics. Infracanal fractures means the fracture line originates from the canal and tends to extend outward. Extracanal fractures, they start from the external tooth surface and tend to go inward. Communicating fractures means through and through fractures. These are the three categories of fractures that can happen in the resected root end whenever we are attempting to prepare a cavity with ultrasonics. The third method is laser preparation. What type of laser we would be using? As we are dealing with a dental hard tissue consisting of cementum and dentine, we would be using hard tissue laser. A hard tissue laser is used. And which are the hard tissue lasers? Most efficient ones? Erbium YAG and erbium chromium YSGG lasers. The erbium YAG laser has a wavelength of 2940 nanometers. On the other hand, erbium chromium YSGG has a wavelength of 2790 nanometers. The two wavelengths are in nanometers. Sometimes we also call it water laser. So you have to remember that these erbium lasers are very efficient in removing the dental hard tissues. They can be used to prepare root and tooth preparation or root and cavity preparation. Advantage: they are most conservative. Second advantage: there is no smear layer generation. And what is the third advantage? There is simultaneous sealing of dentinal tubules. Why there is simultaneous sealing of dentinal tubules? Because of the laser energy, the hydroxyapatite crystals melt and they flow and occlude the dentinal tubules due to melting of hydroxyapatite crystals by the energy of lasers. Simultaneous sealing of the dentinal tubules happens. If we talk about the disadvantage, then definitely the cost. Hard tissue lasers are an expensive piece of machinery, not available everywhere. And secondly, it has a learning curve associated. Learning curve means we have to learn to use the lasers because most of the time we would be working in a restricted area of the mouth. So using a laser requires a lot of expertise and learning curve. These are the two disadvantages of preparation using lasers. Okay, this is how we prepare the root and tooth preparation. The next step would be root and conditioning. Once the root end is prepared after a section, we do conditioning. Conditioning has got two functions. Why do we condition the root after tooth preparation? Firstly, it removes smear layer. We know that if we are using either the handpiece and burr or the ultrasonic method of tooth preparation, smear layer would be generated and it has to be removed, enhance the seal of the root and filling material inside the prepared cavity. Second function to be achieved is it exposes fresh collagen. that promotes regeneration of tissues. It would expose the fresh collagen of the dentine that would liberate certain growth factors like transforming growth factor beta 1, bone morphogenetic proteins, etc., that would enhance the regeneration or repair of the periapical tissues. So these are the two functions that we achieve by root end conditioning. What are the agents that can be used for conditioning the routine? Different chemical agents can be used. The first one is that definitely 17% EDTA can be used. This EDTA, you must be knowing, has a pH in the range of 7.2 to 7.3. This EDTA is applied for 2 to 5 minutes. Okay. And it conditions the tooth surface, means it would remove the smear layer and it would expose the fresh collagen. An important consideration is that it is not to be used with EDTA when MTA is planned as root and filling. When we are planning to use mineral trioxide aggregate as a subsequent material to fill the root and cavity, it is not recommended to use EDTA as a conditioning agent. Why? Because EDTA interferes with hard tissue regeneration property of MTA. Okay, we know that MTA has a unique property that it stimulates the calcified tissue formation against itself that helps in periapical healing and regeneration. That property is interfered with when we are using EDT as a root and conditioning agent. So the manufacturer does not recommend EDTA to be used with MTA. The second agent that can be used for conditioning of the root surface is doxycycline hydrochloride. This doxycycline hydrochloride has a pH of 1.8 and it requires the time for conditioning as less as 30 seconds. The third agent that can be used is 50% citric acid, which has a pH of nearly 1. It is also used for 1 to 5 minutes. These are the three principal agents that can be used for conditioning the resected root end through which we have prepared the cavity before putting the filling material into it. And only exception that you have to remember is EDTA should not be combined with MTA as a filling material. Okay. The next step would be root end filling. Root end filling. See, root end filling can be done with different materials, which are called root end filling materials. Of the various category of materials available, the contemporary materials can be listed into the following types that can be used for root end filling. First ones are the modified ZOE based materials. Modified ZOE based materials. Modified ZOE based materials are the two principal examples of them are IRM and Super EBA. What is IRM? IRM stands for intermediate restorative material. Super EBA is ethoxybenzoic acid. Super EBA. These two are modified ZOE based materials If we talk about the sealing ability of IRM is almost similar to that of Super EBA, and both are greater than dental amalgam as a root and filling material. Conventionally, dental amalgam has been used as a root and filling material also, just like the coronal filling material. But in the strictest sense, if we talk about contemporary endodontic practice, amalgam is not recommended anymore as a root and filling material. There is no hard tissue barrier formation with these materials. What materials? Both Super EBA and IRM have no hard tissue forming capacity. They would simply seal the root apex without any promotion of calcified barrier being formed against them. The second category of materials are composite resin based. Composite resin based materials. A specific material that is based upon composite resins and to be used as a root and filling is retroplast. Retroplast. Okay. It is called retroplast. And another material that is a combination of glass ionomer and your resin is jerry store. Two examples of resin based materials used specifically for root and filling. Both show hard tissue barrier formation. Both of them show hard tissue barrier formation. So it is an important property that whenever we are using a certain material as a root and filling, it should not only seal the interface very well, it should also promote the formation of reparative calcified tissue against itself. And I'm always saying a reparative calcified tissue. I'm not specifying this calcified tissue can be bone, it can be cement. Okay, and least likely to be formed is dentine, because for dentine formation we require specialized cells called odontoblasts which are present in the pulp, and the pulp is not there. So which tissue, calcified tissue, is most likely to be formed against such materials? It would be cementum, most likely calcified tissue to be formed. And the second most likely tissue to be formed is bone, least likely dentine and enamel. Okay, the third is a polyketone material. Polyketone material. Okay. Jerry store is basically a suspension of both resin and ionomers. It consists of certain ionomer components also. Polyketone material is a dicat. Dicat. Dicat is also used as root canal sealer. So it has got dual functions. It is a polyketone material, dicat. Important and easy to remember. The word KET is coming, so it is a polyketone material. Okay. Someone is asking me from where I have done my PG. I have done my PG from GDC Jaipur, Government Dental College, Jaipur, Rajasthan. Then we have calcium silicate based materials. calcium silicate based materials. They are the most suitable type of materials to be used as root and filling. And the most conspicuous example is MTA for these materials, that is mineral trioxide aggregate. Okay. This mineral trioxide aggregate basically promotes heart tissue regeneration by stimulation of fibroblast, secretion of two important factors, that is bone morphogenetic protein 2 and 7 and transforming growth factor beta 1. Okay, fibroblasts are present over there. These fibroblasts, they are stimulated to release these two components that promotes the formation of our reparative barrier. And again, I am telling you which reparative barrier is most likely to be formed. It is a cementum, most likely calcified tissue to be regenerated. Cementum. This MTA and other similar materials, they are grouped together as calcium silicate based materials. Other examples are biodentine, bioaggregate, endosequence, root repair material, MTA plus, and MTA angulus. What are these? These are the examples of a group of materials called calcium silicate based materials. The most conspicuous and the prominent example is mineral trioxide aggregate. Today I am not discussing the detailed properties of MTA. That would be the topic for some other session. Right now you remember what class of material is MTA. MTA is a calcium silicate based material, which is an important property of stimulating the fibroblast, and that helps in formation of a calcified barrier against themselves. Then surgical site closure. Once we have done the root and filling, we have to do closure of the surgical site. For the closure of the surgical site, at times we can achieve hemostasis with certain local hemostatic agents. Okay. And these local hemostatic agents cannot be used, means can not only be used after the completion of this step. At times, whenever we have refracted the flap and before gaining entry to the bone or after gaining entry to the bone, whenever we encounter copious bleeding from the surgical site due to inflammation and a lot of granulation tissue formation, we can use these local hemostatic agents to produce a bloodless field. But remember, which is the initial most important step to achieve a good hemostasis? Use of a local anesthetic with a high concentration of epinephrine in the ratio of 1 is to 50,000. What are the different commonly used local hemostatic agents? They can be cellulose based materials, which are consisting of oxidized, regenerated cellulose. Example is Surgicel. These regenerated cellulose materials, they act as a physical barrier. They have no chemical action on the bony crypt and the blood vessels. Simply, they act as a physical barrier which consists of oxidized regenerated cellulose. Example is Surgicel. Then we have collagen-based materials. Collagen-based materials, they are resorbable. They stimulate chemical reaction like platelet aggregation and adhesion. We know that blood clotting requires these important steps in which there is formation of a platelet plug. So these collagen-based materials that are resorbable, they also stimulate platelet aggregation and adhesion. Example of collagen-based materials are colastat, instat, and hemocollagen. These are collagen-based materials. Then we have gelatin-based materials like gel foam. What in the brackets? And the brackets, I'm giving you some examples of each of the materials, local hemostatic agents. Gelatin-based, they stimulate intrinsic coagulation pathway. Intrinsic coagulation pathway. Then we have bone wax as a local hemostatic agent. This is a very old local hemostatic agent and it consists of 88% beeswax obtained from honeybees and 12% isopropyl palmitate composition of beeswax. But this beeswax, it impairs wound healing and it has got a physical action. It does not stimulate the intrinsic pathway or does not stimulate the platelet adhesion and aggregation. It has a physical action just like cellulose. So because it impairs the wound healing, it is generally not recommended to use bone wax. Then we have ferric sulfate. And ferric subsulfate. Ferric subsulfate is also called Monsell solution. Okay. This also causes necrosis formation, necrosis and coagulum formation. So they impair the wound healing. Also not recommended. Then we have calcium sulfate as a local hemostatic agent. This calcium sulfate is commercially available as one of the trade names, Capsat. Okay. This also has got a physical action, can be used successfully, calcium sulfate. And finally, we have epinephrine pellets. Epinephrine pellets, cotton pellets that are impregnated with epinephrine, that is racemic mixture of 0.55 milligram of epinephrine is present in the pellet. Racemic means it would consist of both dextro and the levo forms. You must be knowing what is a racemic mixture. It consists of both dextro and the levo forms, and this levo form of epinephrine is the active form of epinephrine. Resilate. These are the cotton pellets that are impregnated with 0.55 milligram of racemic epinephrine, consisting of equal amounts of dextro in the levo form, and the levo form is pharmacologically active. But it is to be used cautiously in case of cardiac patients because it has a vasoconstrictor property. And secondly, these cotton pellets, they can impair wound healing. Okay. These cotton pellets, the cotton fibers, they can get stuck into the bony crypt and they can are very difficult to remove and they can impair the wound healing. So these are some of the important local hemostatic agents that can be used to achieve bloodless field and their important properties. The closure of the surgical site is done with sutures. Sutures can be used in both resorbable and non-resorbable forms. Most of the times, because we have to remove the sutures early in cases of periradicular surgery, non-resorbable are preferred because resorbable sutures like chromic cut sutures, cat cut sutures, PGA, etc., they require a longer duration. Sutures after periradicular surgery are usually removed 48 to 96 hours, or we can say 2 to 4 days later. Conventionally, were removing the sutures by say about 1 week or 10 days, but contemporary recommendation is they should be removed 48 to 96 hours or 2 to 4 days after surgery. This allows for better wound closure. Some of the newer non-resorbable sutures, they can be Teflon coated. Very smooth sutures, Teflon coated sutures. Example is Devdec. Okay. Or they can be polybutylate coated. Polybutylate coated. Polybutylate coated example is Ethibond. Synthetic sutures, which are very smooth, a coating present on them, and the most common size usually recommended is 50 size. 50 size. Very fine sutures we use for these surgical procedures. And what is the post-operative care? We would give some drugs to the patient. Drugs consist of painkillers. The most preferred painkillers are the non-steroidal anti-inflammatory drugs and antibiotics to take care of the infection. These antibiotics can be either the tetracycline group of antibiotics or penicillins. Tetracycline group of antibiotics have the advantage that is they promote the bone formation. They are anti-resorptive. And then we get to give chlorhexidine mouthwash to the patient. Chlorhexidine mouthwash to the patient to take care of the infection. These are the different steps which are used and involved in the periradicular surgical procedures. If we talk about anatomic locations where surgery is contraindicated, certain anatomic locations like mandibular premolar region. Why premolar region? Because just below the mandibular premolar, especially below the mandibular second premolar, we have a mental foramen. And if we attempt periradicular surgery, we are likely to damage the nerve over there. Why mandibular premolar? Due to proximity to mental foramen. Similarly, we have to avoid it in the mandibular second molar and third molar areas because the buccal bone is very thick and it is difficult to gain entry to the root apex. Similarly, in the maxillary third molar areas, these are the anatomic locations where it is least desirable to do surgical interventions. Otherwise, they can be done in majority of the teeth groups. These are the important aspects of periradicular surgery. I'm specifically spoken about periradicular surgery today and not other different types of other surgeries. There are different surgeries also like fistulative surgeries like cortical trephination, incision and drainage, etc. There can be corrective surgeries like intentional replantations, redisection, hemisection, etc. That would be the subject for some other session. I have specially focused upon the periradicular surgery, means where we take care of the pathology of endodontic origin. Okay. These are the important high facts about the periradicular surgery. With this, I am signing off. Thank you everyone for being with me tonight. See you next time in another interesting topic related to the subject of cons and endo. Till then, happy reading. Take care of yourself. Thank you very much. Good night, everyone.